VH and VG in PVD. Dr. Munmun Roy. So next, I'll request Dr. ALKA Ravi to be present. After Dr. Munmun, be ready with your presentation. Okay, Dr. Alka? Yeah, okay. Thank you. So she'll be presenting BARDET syndrome with typical retinitis pigmentosa.
A very good afternoon to all. My topic is BARDET syndrome from ophthalmology perspective. A 8-year-old girl presented to OPD at GLMCH Bhagalpur, Bihar with the main complaint of poor vision for 3 years, especially at night in both eyes. Her medical history suggesting of she was a second child of full-term vaginal delivery from a consanguineous marriage. According to her father, she is following up with pediatric clinic for assessing her with daughter's difficulty in swallowing, language delay, delayed milestones, polyuria, polydipsia, and progressive weight gain. There was no positive family history. Upon general examination, the patient had subnormal intelligence, central obesity, a moon-like face, and some dysmorphic features like low hairline, depressed nasal bridge, and post-axial polydactyl. On ophthalmological assessment, the best corrected visual acuity in right eye was 6/60, and in left eye it was PL positive. Patient had nystagmus in both eyes, and her refractive examination reveals myopic astigmatism with a very high spherical power and cylindrical power. Her fundus photograph shows a typical retinitis pigmentosa with pale optic disc and arterial attenuations and the bony spicules in the peripheral retina. As the patient had nystagmus, she was not able to focus on the OCT, and her left eye was showing optic atrophy, which has been seen through indirect ophthalmoscope. Basic lab workup including the complete blood count, fasting blood sugar, thyroid stimulating hormone, and liver function test, which was within the normal range, but she had an elevated triglycerides. So we referred the patient to higher center for genetic workup and a possible mutation consistent with BARDET syndrome. A thorough search of literature and with clinical findings, our patient fits into the diagnosis of BARDET syndrome. Discussion. Bardet-Biedl syndrome is a rare autosomal recessive genetic disorder which leads to the dysfunction of multiple organ systems, including the kidneys, genitalia, brain, and eye. It caused by the mutations of proteins involved in the cilium, and the most commonly exhibited feature was retinal rod cone dystrophy. Clinical confirmation can be done using a revised criterion that consists primary or major features and secondary or minor features. Primary features include hypogonadism, polydactyl, obesity, retinitis pigmentosa, and learning disability, whereas the secondary features include ataxia, speech abnormalities, developmental delay, and diabetes mellitus. According to this, our patient had central obesity, polydactyl retinitis pigmentosa as primary features, and poor coordination and developmental delay as secondary features. Thus, it established the diagnosis of Bardet-Biedl syndrome. Thank you.
So what is it that you're trying to bring out from this presentation? Is there anything in mind?
No, ma'am, there is nothing. I just want to present that, I just want to report a case of Bardet-Biedl syndrome. She was presenting to our OPD. So, ma'am, I have prepared this much.
So there are many syndromes with retinitis pigmentosa.
Yes,
some Usher syndrome, which has hearing abnormality, lot of them with renal abnormalities. And there's a Lawrence-Moon syndrome, which does not have polydactyly and obesity, but has other things.
Yes, ma'am, like
Lawrence-Moon, yeah.
Yes, ma'am, Lawrence-Moon.
And then you can have both Lawrence-Moon and Bardet-Biedl, where you have everything.
Yes, ma'am.
So these are basically just an autosomal recessive genetic disease, which can be very severe. They are not very uncommon in the South India because consanguinity is so common in South India. So since I shifted to South India, we see a lot of these cases because they marry in their relationships. Yeah, there has to be an awareness. When we see such a patient, we have to talk to the family not to have consanguineous marriages in the future, at least.
Yes,
Anything anybody wants to add?
One doubt I always have for this rare genetic disorders, do we always need to do a genetic counseling, genetic testing before being able to present on such podiums? Because everywhere on each case report it is told that we didn't perform it. But when the symptoms are so obvious, do we really need to do genetic testing, ma'am?
See, presenting in a podium like this where you don't have much, at stake. But if you are presenting at a place where you want to deliver a particular message with that case. Now here there is no particular message. I asked her what's the message. So if there's a particular message you want to deliver, there has to be a genetic subtype to say that this subtype causes this problem, and hence we have to see whether other genetic subtypes also cause this problem. So when there is a,
A firm message to be delivered. then
yeah,
it is-
yeah, yeah. See, it has no bearing on treatment or management. So I don't think it should be done for any case at all, unless we are planning particular treatment depending on the genetic type, which we don't have. Except Luxturna, which is an intravitreal gene therapy. Luxturna is done for a particular genetic subtype of retinitis pigmentosa. So for that, they do a genetic typing, but we are not offering Luxturna to anybody.
Thank you, Dr. Alka.